for today is to talk a little bit about the why we want to do this. And some of this is with the regulatory lens, and then some of this is from a person-centered lens, to go into a little bit of what might be some best practices, and then really kind of go down the road as far as in other groups.
So we're not able to hear you very well at all when you started the recording. So I don't know if the volume can be changed at all.
Okay, thank you. We're fiddling with it for a moment.
This is still with it out.
Okay. There might be a volume.
So
setting.
Heather, how does this sound now? Does it sound a little bit more clear?
Yeah, it sounds good.
Are we sharing? Okay. And does it still sound okay?
Yes, thank you.
I may have to, one of the issues with the technology we're using is it's very speaking into it dependent versus I have to look one way, but then my slides are over here. So let me know. All right. So basically, yeah, we'll see how far we go in the time we have. With that, I think you can go to the next slide. I've been giving this talk for, gosh, a number of years that several years ago when I started at All Care, one of my chief operating officer thought it would be great if I went and took some of the WPATH training, which is the World Professional Association on Transgender Health, which was fabulous, and I heartily recommend who's able to. This is something that we've done internally for All Care. Also something I've done through the Regional Health Equity Coalition. So Healthy, I was formerly the co-chair for that group for a number of years. This is something I do several times a year, but there's always room for learning and improvement. If this can be a really sensitive kind of subject for some folks, if folks are sharing personal information or anything of that nature, be respectful and maintain confidentiality. If there are any objections, we are recording this for possible future trainings, but if anybody does have an objection to that, please privately message us in the chat, and we will, we can always record it at a later date. So we don't have to keep the recording if that's an issue. Next slide. A large number of the folks on this call are All Care employees. And certainly, our part of our values are to really provide person-centered care, to be respectful, to realize that people may have backstories, and history that we are not aware of, and that may color kind of our present day interactions. And that we want to really provide, the best customer service, the best healthcare that we can for all folks. And that's, irrespective of the differing values that employees may have in their personal lives, that, that our company values are that, our members matter. So kind of basic things, being friendly and courteous, following what we call, the platinum rule, not just treating others as we would like to be treated, but, treating people the way that they would like to be treated. And, this is folks with that are LGBTQ plus, and, there's a number of other initials there. Certainly are one of the groups that can face and stigma in our society, particularly in some of our regions of our service area. and that there are access issues in terms of healthcare that exist, unfortunately. So but you don't have to be a specialist in specific medical or behavioral health or whatever issues, basically to treat people, in an affirming way. The other thing I usually preface this talk about is that language is very important. That we'll get into pronouns and things like that later, but that it's really easy, I think, to just mess up. And I will this many times during this training by choosing the wrong word. It's hard to talk and think at the same time. So we'll talk a little bit about how to address that, but trying to be aware of that this is one instance where it really does make a big difference. Next slide. So, what is the scope of the issue? I tried to update things as much as I could. That, a survey done in 2022 is estimating that 11% of millennials and 21% of Gen Z, which, I was joking with folks, I don't remember which generation is which anymore, but, folks that are younger than I am, let's just put it that way, self-identify as LGBTQ+. The Healthy Teen Survey is done every couple of years for Oregon and surveys 8th and 11th graders. But, based on that, 17.3% of Oregon 11th graders identify as LGBTQ. And specifically when they asked about non-binary or gender non-conforming, that was 5.5%. We do know that there are disparities when there are not adequate supports for people that identify this way, that there's higher rates of poverty, household insecurity, lower incomes, some higher physical health issues, issues regarding insurance, access to medical care. And a lot of that is due to negative experiences related to either sexual or gender identity, and deferment of care because of those negative experiences. Much higher rates when there's not support in terms of behavioral health issues. Suicide rates are 4 to 5 times higher in terms of suicide attempts versus folks that are either identify as heterosexual or have supports. Higher risks of intimate partner violence and higher incidence of depression. Next slide. There's a lot of issues with school safety and, missing school, decreased grades, much higher issues in terms of family issues, in terms of abuse or being kicked out of the house. And I think for those of you that work with some of our, housing providers in the area, Hearts with a Mission, folks like that, there's really a disproportionate number of the kids that they're housing are LGBTQ. And then health behaviors, some increased rates of, health behaviors with negative impacts potentially. Because of the combination of really all these issues. And, I think a lot of these aren't intrinsic to being LGBTQ, but it's as a result of stress related to, some of these other issues. Compounding this is if you, are a person of color or have other intersectional identities that, tend to be marginalized, then this is much higher incidence. Either it's kind of an additive negative impact if you have other marginalized identities. Next slide. And then this is a more recent survey, just showing that for folks that are 13 to 24 years of age, about 28,000 LGBTQ specific young people were surveyed by the Trevor Project. 41% reported considering suicide. Although folks indicated that if they had something as simple as respect for their pronouns, that could lessen that. Over half could not access behavioral health care. Fewer than 40% that is supposed to be, found their home to be affirming. And then it was 50-50 really in terms of whether school was a supportive place or not. So this is current data. Next slide. As I mentioned, if there is support, that this can really normalize a lot of these issues, that housing, is better life satisfaction, behavioral health issues, and suicidality, and for children when they have support, that this really has led to much better long-term kind of adult outcomes down the road. Next slide. So what protections are in place? Federally since 1972, Title IX has prohibited sex discrimination in terms of education for institutions that receive federal funding, and this overrides state laws. There are, federal protections in terms of names and pronouns in school. This does not require a legal change or evidence of, any sort of medical intervention. I think this is still sometimes confusing to the school systems, that this is student-led. Does not have anything to do with parents, etc., and may be private. This may be school specific, because what is safe for a student at school may be very different than what is safe for them at home. And so I know, several years ago, I did this training for the school districts, and specifically, their sex ed or, kind of health instructors. It's probably time to do it again. And you guys will get a copy of the slides. One of the criticisms has been I put a lot of words on the slides, but I'm a big believer in information. So, if you can't, you don't have to write it all down now. You'll get a copy. The other thing that comes up a lot in terms of schools are bathrooms and showers that, students must be allowed to use the bathrooms and showers that they choose. It cannot be kind of a separate facility unless they so choose, but having a transgender student use a private bathroom when everybody else is in a shared bathroom is not legal, again, unless that's their choice. The same thing goes with dress codes, that a school can have an overall dress code that applies to all students, but they cannot discriminate based on the school's perceived gender of that individual. So, if spaghetti straps are allowed, they're allowed for everybody, or what have you. And then, privacy is paramount, and, the educational equivalent of HIPAA is called FERPA, which is the Family Educational Rights and Privacy Act. But again, that this does cover that, a student can indicate the name that they use at school. It may differ from the name or pronouns they use at home. And, unless that student is given permission, that's not information to be shared outside of school. And all of these protections apply to non-binary students. Next. In Oregon, actually, I just was looking at a map in the last week that showed for the United States, kind of which states were high-risk states, which states had the most protections, and Oregon was #1 in terms of legal protections. The 2007 Oregon Equality Act basically outlawed discrimination based on sexual orientation or gender identity. We have covered medical treatments since 2014, that puberty suppression is covered. A little bit later on, transgender, gender affirming healthcare treatments are covered by OHP. Conversion therapy is something that's been outlawed by a number of states, including Oregon, and this is a discredited treatment. I mean, the American Psychiatric Association and all medical associations and behavioral health associations do not support this, that, you know, holds that you can basically change somebody's, you know, gender identity or sexual orientation through therapy. In some cases, this has led to, you know, physical harm and even death. Some of the lay attempts to do this. There's a gender X option on driver's license. You know, the comprehensive sexuality education that Oregon has from kindergarten through 12th grade does include some of these concepts. Now, this curriculum is based on, you know, age and developmental levels. So certainly what is presented to a kindergartner is very, very different than what would be presented to a high school student. And, you know, really is, you know, again, based on age appropriate and developmental levels. But this is part of that curriculum. And then it used to be in Oregon that to change your name or to change your sex designation, you had to publicly, you know, put this, you know, put an ad in the paper or advertise this for a period of time before you could do this. And that was, you know, basically that requirement was removed only in 2018. So that is now an option. Next slide. You know, when we talk about gender identity, it is confusing in terms of language because oftentimes the terms gender and sex get used interchangeably. And I think this is one of the things I messed up when I did this last week, even myself, that in this area, you know, when we talk about gender, we're really talking about that internal, you know, internal sense of self and who you are, which may be, you know, it's a spectrum. It's not a black or white sort of thing. When we talk about sex, we're typically talking more about, you know, who you're attracted to and kind of about, you know, relationships. But, you know, again, the terminology is wonky because, you know, we do talk about assigned sex or assigned gender at birth, that these are used interchangeably, and that's based on external genitalia versus, you know, that internal identity. And then, as I said, this is a spectrum. And so originally when this talk was created, it was, you know, really talking about transgender health, but, you know, especially over the last few years, just really talking about, you know, gender non-binary or non-conforming, you know, that I think some of the language is still, I don't like the non-conforming term, although it's used commonly, just because to me, it implies a negative, you know, that there's a normal, and I don't like thinking of this as something that's not normal. So next slide. And then gender expression is really more just the external appearance, you know, how do you choose to, you know, to dress or cut your hair or act or what have you. But this, you know, may vary from day to day. It may vary depending on, you know, cultural influences. Are you with your, you know, with your family? Are you with friends? Are you somewhere safe or not? You know, there have been reports when we've had listening sessions with our LGBTQ communities that, you know, what folks feel comfortable doing in Ashland is very different than what they feel comfortable doing in downtown Grants Pass. You know, so I think gender expression really you kind of have to take with a grain of salt. in terms of, it may not represent somebody's true identity, because again, it just, varies day to day, and situationally. Next slide. And then, medically, the terms that are used, I think sometimes are very negative. When we do requests for gender affirming treatment, they have to have a diagnosis code, and a lot of the diagnosis codes, I think, have a very negative connotation. Gender dysphoria implies that, that there's an unhappiness or, distress as part of that gender identity, which I think does not exist for, the majority of folks in terms of their sense of self. It may apply in terms of societal relations, or gender identity disorder. Again, saying something's a disorder to me is unfortunate, but the medical terminology has not really caught up with this. I like to explain to folks that this is in order to get things coded so that we can get coverage. It's a necessary evil until we can kind of correct that. All right, next. And then sexuality, is a different aspect of our internal sense of self in terms of, who we're attracted to, who we have relationships with. That may change over time. It's variable. It cannot be assumed. I mean, a big thing that, we have heard and is, borne out by national studies is people make assumptions based on sexual identity that, we had members that were lesbian talk about, that, they wouldn't be screened for sexually transmitted infections because lesbians don't do that, or folks that aren't screened for pregnancy when, you have to specifically ask questions about, sexual practices and, to really be able to appropriately counsel someone. You can't assume just by demographics. Next slide. And all of these things are really a spectrum. So, assigned gender at birth, it is typically based on physical characteristics, but there are in-betweens. Intersex is something that used to be called hermaphrodite. That is now felt, I think, by almost everybody to be a negative term. And so, I wouldn't use unless the person I'm talking to, I self-identified that way. But there are, issues in terms of hormones and receptors, and, not necessarily working in the typical way, where it's not always clear what gender somebody is at birth. That, I'm a pediatrician by training, that, I've had a few of these patients over the years, and, the commonplace practice, had been to, based on conversations with the parents and with specialists, to arbitrarily assigned a gender to that child based on kind of a combination of family preference, but also cosmetically what would be possible surgically and with treatment. But we've found over the last few years, as folks with these issues have become adults, that those arbitrary assignments didn't always align with that that person's later identity, personal identity, and created a huge disservice to that person by having irreversible surgeries done to create genital organs. So I know this has been outlawed in some states, until really the involved child is of sufficient maturity to participate in those discussions. And then gender expression can vary from very, feminine to masculine or somewhere in between. Gender identity, may not, is not set in stone, that none of these are black and white issues, that they can vary over the lifespan, as can sexual orientation, that, folks may not be, to one end or the other. And this is another way to display this, in terms of identity is, kind of focused on that brain internal identity. Expression is the outward appearance. Sex are the organs you have, and then, sexual identity is the attraction piece. And depending on your preference, I've seen this with unicorns and frogs or whatever, you name it, that picture exists, I believe. Okay. So, a key thing with all of this is really just trying to normalize the practice of asking folks pronouns, and I think this is becoming more commonplace. A good portion of the time, even though I have it written down, I will tell myself a minute before my mouth opens to say my pronouns. I forget this all the time, but it really, I think will help normalize this as a society in terms of not assuming, making assumptions about folks. We're all familiar with she, her, he, him, they, them. The Z here, here's is one that's common, although from what I'm told, this is more common on the East Coast. There are, I think, some more individualized pronouns that my kids have told me about nowadays. I'm not aware of any widespread different ones used, but again, it's very individualized. And I think it's just helpful to ask, if you are in a professional capacity, to note it in your chart, your electronic record, to try to really make sure that folks are using this as much as possible, including any other staff members. Next. So this is just, one chart, very simplistic, but trying to do this. My oldest, actually both my children, have indicated this to me. My oldest child prefers they, them pronouns. I've been given somewhat of a pass to screw this up because it's hard to change horses after 25 years, but it's difficult to have the presence of mind, especially if I'm talking fast, to do that. So, and I'm trying to be better about, saying my oldest child rather than my gendered whatever, daughter or son, but it can be challenging. And then I do this topic, this talk a lot for our interpreter classes. This is very difficult for a lot of different languages, because many languages are heavily gendered just in terms of nouns and things, and so it can be very challenging. And the bottom line comes down to when in doubt, ask that. If you are talking to somebody, especially if it is somebody in another language, how would they like you to use their pronouns? And does that vary depending on situation? Again, it may, you may have a different answer if they are alone versus if they are with their family or whatever. The other thing language-wise that I like to point out is I try to get away, and I don't know if I've said it already, from using the term preferred, because to me that implies an element of frivolity, that it's an affectation rather than being part of somebody's identity. So, I try to either just avoid the word or use affirmed when need be. And I haven't really had a lot of feedback on that. To me, that's just, I would take it that way, I guess, personally. So that's my personal bent. So you guys can weigh in and let me know what you think. Next slide. This is something that we've tried with our in-person groups sometimes, is just trying to think about, working in small groups that, if you did have to, if this isn't part of your identity and you were having to think about, being, gender non-binary or transgender, or, being, gay or lesbian or whatever, how would this impact you in your life differently than it does now? Are you comfortable, fully expressing yourself in public or showing affection? Are you able to, be your true self, with your friends and your family at work? Any of that, just what do we take for granted? And, I had a friend, that had been in a long-term committed relationship, same-sex relationship, that went to see family back east and had to suddenly, while traveling with their partner, refer to their partner as their good friend or their roommate. And just, how terrible that would be, at any point, let alone after 25 years, to have to play that game, that how awful that is. So, just trying to think about those things. And then it's, it can be, easy, as I said, to mess up and to misgender somebody. And, best practices would be, if you recognize this, to briefly apologize, to acknowledge that you made the mistake, because that means the world to folks, but then to move on. That sometimes, when an apology becomes too drawn out or effusive, in essence, it's making it more about the person apologizing and not about the person that was misgendered. So, just that would be kind of a word to the wise. There's a couple case scenarios you'll get with your packet. This is a story about Annika, who was at their doctor for an appointment, asked to use the restroom, and was told the men's restroom is over here. That did not align with how Annika self-identifies. And so rather than use the restroom or correct this, Annika sat back down and didn't use the restroom when they needed to. So just, that this isn't just ourselves as individuals, but again, if we do, are part of larger offices or systems, really trying to make sure all of our staff, understand this, and again, trying to be as neutral as possible, and if possible to have gender neutral bathrooms as well. Now, this is something at all care. I think our public bathrooms are gender neutral, but our employee bathrooms are not. I would love to see change down the road, although I have no idea what men's bathrooms look like, but so I think there's still work to be done here. There's a lot of media concern about assaults in bathrooms and things by people having folks that might be gender non-binary or trans in their bathroom. The reality in terms of any sort of violence is that the person that is, gender non-binary or trans is at much higher risk for something being instigated against them than for a cisgendered person being assaulted. So, I think that's a common misconception, but it's not accurate. This is just a best practice sort of explanation about how that conversation might go with somebody in terms of assessing pronouns, etc. And then, it is important, not just from a statistical standpoint, but also in terms of healthcare, to collect data about, both racial and, ethnicity and disabilities, but also sexual orientation and gender identity. In some instances, this is required by law. Federally qualified health centers have to collect this information. I know that this is the Oregon Health Authority is, on the verge of implementing this for a number of other systems, although it keeps getting pushed back.
Community health assessment.
Yeah, and I know they just said on a meeting this week that it's now being pushed back to December. We'll see what happens. So I'm just going to show you some of the draft paperwork of what this might look like. Next slide. And there's many ways to do this. The big issue is if you have an electronic health record, what they will support. But this is the OHA form, really asking about gender, asking, specifically about sexual orientation. Next slide. Sorry, this is very teeny, but, asking about, affirmed name versus legal name. And it is important to have both if, for insurance purposes, if your affirmed name is not your legal name, you may not have coverage if the wrong name is submitted. You may not be able to get a prescription filled if that is not done. Let's see. And then, getting down to the middle of the page, needing to know, what was your assigned, sex at birth. I think the next page goes on to, have you had surgeries or other treatments? Who do you have, sexual partners? All of this, because these can impact, in terms of physical health, what sorts of assessments need to be done. That, if you were a person born with a cervix, you need to still, and you have not had surgery to remove that cervix, you still need to have a pap smear. If you're a person born with a prostate gland, you still need to, have that evaluated for cancer. There's, huge issues in terms of breast cancer screening, for folks that are transgender or have had any gender affirming surgeries, making sure that, appropriate medical care is still done. And then, folks that are on hormone therapies, those are not always ideal with certain health conditions. And so it creates conversations that need to be had about priorities in terms of, you have severe coronary artery disease, this might be an issue, what are we going to do about that? I know they've seen with some cancer therapies and gender affirming hormone therapy that could be an issue. And so I think the oncology community is trying to deal with, having how to have those conversations, although I think it's really as simple as having a conversation, saying this is what we know, this is what we don't know, what is the most important thing to you, and trying to counsel accordingly. But it can feel very invasive, for somebody that has had any of these treatments or surgeries, especially if it's somebody that's transgender that has had a lot of different therapy, but to still, if you identify as, trans male and you have to have a pap smear because you still have a cervix, nobody likes pap smears to begin with, but imagine how awful that would be if you identify as male, or, prostate exam or whatever, that these are really, very emotionally charged kinds of interventions and need to be really handled very sensitively. Next. So the goal is, really to, identify, and so that we can appropriately counsel folks and be respectful, but, make sure that our patients and members, are, appropriately informed and treated with courtesy. But really, other than that, it's still primary care. If you're a healthcare practitioner, it's still behavioral health. I mean, it doesn't, and not everybody that's, gender non-binary or transgender, it doesn't mean that everybody wants all of these treatments, your internal sense of self, again, what someone needs to, maximize that is very individual about where that goes. Next. All right, and I think we talked a little bit about this. Next slide. The risk is if this is not handled well, again, if there's that poor, interaction at the front desk or, or with the provider, is that folks will not seek healthcare, or they will go to, the other areas to try to obtain what they need. And there definitely is a black market, for hormones, for different interventions. This could lead to somebody that really has severe risk factors, undertaking something without appropriate education that might put them at jeopardy, or side effects, dosing, or, for things that are injectable, whether that puts somebody at risk for, hepatitis C or HIV or something from needles. So, I mean, we really, want to develop, respectful relationships so that we can provide appropriate, safe care. And then behavioral health, there's a couple of roles. I mean, one is just if there is an element of distress related to gender identity, obviously that can be very helpful. I mean, a lot of us have other reasons for distress in our lives. I mean, I'm a big proponent for behavioral health and eliminating the stigma anyways. For somebody that is seeking gender affirming surgeries, for OHP coverage, behavioral health assessments are required. And that is to just ascertain that, that there aren't other confounding issues, which sometimes occur in terms of behavioral health diagnoses that might make that decision possibly, more questionable until one thing has been stabilized. And, just to kind of ascertain that for chest surgeries, either breast reduction or breast augmentation, one evaluation is required for OHP. For genital surgeries, it's two separate providers need to assess somebody. And part of that is just related to the difference in how complicated these surgeries are. The genital surgeries are very detailed and oftentimes require multiple procedures. Now for, for minors, that this is usually part of treatment also, in terms of just really assessing whether, the young adult or child in question, where things are at in that process. I mean, typically there's no rush to doing gender affirming surgeries in pediatrics. That until puberty is starting, there's, it really is more about supporting the child and family so that, if there is distress about a gender identity for a child, how are we going to address that in terms of clothing and haircuts and school and if there's a disagreement between, parents or guardians, things like that, is, how are we trying to minimize the overall distress, in the entire family so that that child's distress is hopefully lowered or eliminated. When puberty is starting, there is a little more urgency in terms of assessment. And that's the role for puberty blockers. Puberty blockers literally, are blockers. It puts a pause. They're medications that basically can stop the progression of puberty for a period of time, which sometimes is necessary to work through these issues. And so it can be very helpful. They're fully reversible. It doesn't cause any overall long-term effect on whichever way this goes later in life for a child. And then, if basically there is an agreement, for a child that they are transgender, and, that's kind of an assessment of the child, discussing with the family, etc., then potentially, gender affirming hormones might be started. And typically that's kind of a titration scenario that you're trying to mimic puberty, for that gender, while minimizing, the effects of the kind of gender at birth. Part of this is for somebody that's transgender, if you can, if you can address these pubertal changes at puberty, it's much, much easier than trying to, for gender affirming care, once you've gone through puberty, is more challenging and does not necessarily have, at least from a cosmetic standpoint, does not work as well. And it's, typically, I think for trans men, that's tends to be a better cosmetic outcome versus trans women, that reversing the effects once testosterone has started is much more challenging and leads to, if desired, a lot more surgical procedures than than for trans men. Just testosterone, unfortunately, is a very potent hormone. The main thing would be height. Height for a trans male, if they've gone through puberty, is not something, that's going to be impacted significantly, versus if that's identified during puberty, you might get a couple more inches out of things. So, and these are some resources. So I guess I think we have a few minutes if people have questions. I think that's a lot at once. Hopefully I didn't mess up my words too much. I think there's like 5 pages of resources, so there'll be a ton of resources. We can also send out, there's a glossary that talks about a lot of different terms that we can send out also. So questions or feedback, what was helpful, what's not? What are you seeing in your own, professional or personal lives? Hi, Kevin. Yeah. Okay, so Faye Fair, is that in terms of pronouns? All right. And how was it? Were folks at Pride last weekend? How'd that go? Well, if nobody has any questions or comments, I'll let you go, but thank you very much. We will be sending a evaluation form, if you can please fill that out and give any feedback. And again, yeah, there's suggestions or anything that would be helpful, and otherwise we'll talk to you later, and thank you very much.
Thank you.